So at this ASH, we're very excited to present the updated efficacy and safety analysis of the LINKER-MM1 study, which is a phase 1/2 first-in-human safety and efficacy study of Regeneron 5458, now known as Linvoseltamab, in patients with relapsed refractory multiple myeloma. So at last year's ASH, we had presented data from the phase 1 study, which was mostly safety data, and we now have more efficacy data from that cohort as well. So the study is now close to accrual, recruited a total of 252 patients with relapsed refractory multiple myeloma. It is very important to know that this is a fairly heavily pretreated population with a median of 5 prior lines of therapy and with a fairly high disease burden. So the median serum BCMA level was 0.43, which is higher than some of the other bispecific studies, and about 37% of the patients had more than 50% of plasma cell at the bone marrow biopsy and registry to the study. In the phase 1 part, the dose escalation was done up to the 800 milligram cohorts, and there was no there was no MDT, maximum tolerated dose, found. For purpose of the phase 2 study, the dose required or that we went with was 200 milligrams. So there's two cohorts. There was a 50 milligram and 200 milligram cohort. There was a ramp-up approach used to mitigate the risk of cytokine release syndrome with CRS. And after week 16, the dosing went to 2 every 2 weeks. So in terms of safety, the most common hematological adverse event was anemia, and the most common non-hematological event was cytokine release syndrome. So the incidence of cytokine release syndrome in this specific study was 44%, which is actually much lower than a lot of other bispecific studies, and the majority of these were grade 1. And the use of tocilizumab, which is used to treat severe cytokine release syndrome, was only 11%. The cytokine release syndrome was fairly predictable, with median onset of duration of 11 hours after infusion and median duration of 15 hours. So predominantly done within 24 hours. We also looked at ICANS, which is neurotoxicity. That was seen in about 5.6% of patients, but only 1.2 had grade 3 or more. Infection was a big issue at 54%, but only 29% was grade 3 or more. We did have opportunistic infections, mostly CMV and PJP, in this population in 4% of patients and 3% with grade 3 or more. In terms of efficacy, the response rate for the 200 milligram cohort was 64%, with a VGPR rate of or higher of 45%. We did assess for MRD, and out of those that were evaluable, 60% were MRD negative. In terms of duration of response, in the 50 milligram cohort, for which we have longer follow-up data, about 61% of them were still responding at 16 months. In the phase 2 cohort, the follow-up data is a little less, but 81% were still responding at 6 months. So overall, we're very excited about bispecific and T-cell engagers in general in multiple myeloma, and we feel that this specific compound, it has a very acceptable and manageable toxicity profile, but also has really good efficacy, and definitely needs to be looked much forward in multiple myeloma. So with that in mind, there's another amendment for subcutaneous formulation for this product in the LINKER-MM1 study, and there's also a LINKER-MM2 study, which Dr. Rodriguez-Ortega presented a poster for Linvoseltamab in combination with other compounds such as daratumumab, carfilzomib, and lenalidomide.